Asthma originates from a Greek term that translates to short-drawn breath, or panting, aptly describing the breathing difficulties experienced by those with the condition. It is a chronic inflammatory condition of the airways that causes airway obstruction and is characterized by recurrent episodes of difficulty breathing, coughing, and wheezing. It is seen more frequently in children and falls under the obstructive lung disease category. The etiology of asthma is complex and not fully understood. However, it develops in individuals due to a combination of genetics and environmental factors. The most significant risk factor is atopy, which is a genetic tendency to develop allergic diseases such as allergic rhinitis, atopic dermatitis or eczema, and asthma. Atopy tends to run in families, so having a parent or close relative with allergies increases the risk of developing asthma. Other risk factors, which can also serve as triggers for an asthmatic attack, include environmental allergens such as house dust mites, animal allergens, especially from cats and dogs, cockroach allergens and pollen, gaseous irritants such as smoke, fumes, sprays, and perfumes, viral respiratory tract infections, medications such as aspirin, non-steroidal anti-inflammatory drugs and beta blockers, physical activity, cold air, stress, and expressing strong emotions like grief. Asthma attacks or acute exacerbations occur when triggers such as environmental exposures meet genetically susceptible individuals, resulting in airway inflammation and obstruction. The primary mechanism responsible for the inflammation and obstruction in asthma is airway hyperresponsiveness, where the airways of individuals with asthma are overly sensitive and produce an exaggerated response to certain triggers. It's important to note that these same triggers would produce little or no response in non-asthmatic individuals. This heightened response leads to three main features that cause the airflow obstruction observed in asthma: constriction of the airway muscles, also known as bronchoconstriction, airway edema, and increased mucus secretion. Let's take a closer look at what happens at the cellular level. During the initial encounter with the allergen, which is the sensitization phase, dendritic cells play a crucial role. They capture the allergen and process it before presenting it to naive T helper cells. This interaction causes the naive T helper cells to transform into T helper II cells. Once differentiated, these T helper II cells begin producing cytokines, particularly interleukin-4, interleukin-5, and interleukin-13. Interleukin-5 recruits and activates eosinophils, which are white blood cells involved in the inflammatory response. Meanwhile, interleukin-4 and interleukin-13 stimulate B cells to produce IgE antibodies. These IgE antibodies then bind to the Fc receptors on mast cells, effectively sensitizing them to the allergen. At this point, there is no immediate reaction. The mast cells are now primed and prepared for any future encounters with the same allergen. When the individual is exposed to the same allergen again, the allergen binds directly to the IgE antibodies on the surface of mast cells. This binding causes the IgE antibodies to cross-link, triggering the mast cells to release their contents in a process known as degranulation. When mast cells degranulate, they release a mix of substances that trigger inflammation, such as histamine, leukotrienes like C4, D4, and E4, and prostaglandins. These pro-inflammatory mediators cause bronchoconstriction by directly stimulating the smooth muscle cells in the airways, or by activating the parasympathetic nervous system, which also leads to muscle contraction. Additionally, they increase mucus secretion by stimulating submucosal glands and goblet cells, and cause airway edema by increasing capillary permeability, allowing fluid to leak into the airway tissue space. Mast cells also release chemokines that attract additional inflammatory cells, including T cells and eosinophils, to the site of inflammation. Activated eosinophils produce proteases that further exacerbate the inflammation. Initially, the inflammatory changes in asthma are reversible. However, with frequent and prolonged attacks over many years, these changes can become permanent, making reversibility difficult. This is termed airway remodeling. Airway remodeling involves several structural alterations, including subepithelial fibrosis, where scarring occurs beneath the airway lining, and thickening of the basement membrane. It also involves an increase in mucus production due to larger and more numerous mucus-secreting glands, an increase in the smooth muscle mass, and increased formation of new blood vessels. The presentation of asthma can vary, but common symptoms include wheezing, coughing, especially at night, shortness of breath, and chest tightness or pain. It is important to identify the trigger for the current episode, any previously known triggers, and other signs of atopy, such as itching of the eyes, nose, or throat. Additionally, consider the patient's current medications, significant past medical history, and whether there is a family history of asthma or atopy. Physical examination findings in asthma can vary, but key indicators to observe include signs of respiratory distress, such as central or peripheral cyanosis, tachypnea, and the use of accessory muscles for breathing. On palpation, look for reduced tactile fremitus and decreased symmetrical expansion of the chest wall. Percussion may reveal a hyperresonant note, and auscultation might show diminished breath sounds or reduced air entry bilaterally, along with wheezes or rhonchi. The diagnosis of asthma is mainly clinical and involves a combination of medical history, physical examination, and specialized tests such as spirometry. Spirometry is a common pulmonary function test that is used to confirm the diagnosis of asthma. It measures the volume of air exhaled after a deep breath. During the test, the patient is asked to place their lips tightly around a mouthpiece, take a deep breath, and blow out as hard and fast as possible. The main measurements are forced expiratory volume in 1 second, or FEV1, and forced vital capacity, or FVC. FEV1 is the volume of air exhaled in the first second after a deep breath, while FVC is the total volume exhaled after a deep breath. The FEV1-FVC ratio is typically above 0.7 in healthy individuals, usually around 0.8 or higher. In obstructive lung diseases like asthma, this ratio falls below 0.7 due to the obstruction of airflow. A peak flow meter is a handheld device used to monitor how well a patient's asthma is controlled at home. It measures how well a patient can exhale, reflecting the patency of their airways. Similar to spirometry, the patient must take a deep breath and then exhale forcefully and rapidly into the peak flow meter. This process is repeated regularly, and the results are recorded and reviewed by the patient's physician. Over time, patients become familiar with their normal readings, which are the values obtained when they are healthy. These values serve as a reference point, and a decline in readings may indicate worsening airflow obstruction, requiring medical attention. Other tests that can be done include a complete blood count, which may reveal eosinophilia. Serum IgE levels may be elevated. Likely findings in sputum microscopy include Kirschmann spirals, which are spiral-shaped mucus casts of smaller bronchi and bronchioles and indicate mucus hypersecretion. Charcot-Leyden crystals, which are needle-like crystals formed by the breakdown of eosinophils. And Crayola bodies, which are clusters of sloughed-off epithelial cells and indicate epithelial damage. Chest X-rays are usually normal for the majority of patients but can show signs of hyperinflation or air trapping, as evidenced by flattened diaphragms and darker lung fields. Chest X-rays are also performed to rule out conditions that may mimic asthma in presentation, such as airway foreign bodies. Asthma is generally classified as intermittent or persistent based on the frequency of symptoms, how these symptoms interfere with a patient's normal activity and lung function test results. Patients with persistent asthma are further classified as mild persistent, moderate persistent, or severe persistent. Acute exacerbations of asthma can also be classified based on severity as mild, moderate, severe, and life-threatening. In life-threatening acute exacerbations, patients are often too breathless to speak, and the chest may become silent, indicating absent breath sounds or wheezing on auscultation. Other critical signs include bradycardia, hypotension, cyanosis, and exhaustion. Asthma does not have a definitive cure, but it can be managed through a combination of strategies: medication, avoidance of known triggers, and regular follow-up and monitoring. Asthma medications are primarily divided into 2 categories: bronchodilators and anti-inflammatory agents. Bronchodilators play a crucial role in opening up the airways by relaxing the smooth muscles. They are either beta agonists or anti-muscarinics. Beta agonists stimulate beta-2 adrenergic receptors on the smooth muscles of the airways, leading to muscle relaxation. Short-acting beta agonists like salbutamol provide quick relief, while long-acting beta agonists like formoterol offer extended control. Anti-muscarinics work by blocking muscarinic acetylcholine receptors, inhibiting the parasympathetic nervous system's effects on the airways. This results in bronchodilation and reduced mucus production. Short-acting anti-muscarinics such as ipratropium bromide and long-acting ones like tiotropium fall into this category. Anti-inflammatory agents are crucial in managing respiratory conditions and include several types. Corticosteroids are a primary treatment option and come in various forms based on the severity of the condition, such as oral medications like prednisolone, intravenous options like hydrocortisone, and inhaled forms like budesonide. Leukotriene receptor antagonists, such as montelukast, block leukotrienes from binding to their receptors, reducing inflammation. Mast cell stabilizers, such as cromolyn, inhibit mast cell degranulation to prevent the release of inflammatory mediators. Immunomodulators like omalizumab and benralizumab help by targeting different aspects of the immune response. In summary, asthma is a chronic inflammatory condition of the airways that leads to recurrent episodes of wheezing, coughing, chest tightness, and dyspnea. It results from a combination of genetics and environmental triggers. Asthma is typically reversible, but this can change if airway remodeling occurs. The diagnosis is primarily clinical, based on patient history and physical examination, and can be confirmed with spirometry. Management involves avoiding known triggers, using medications such as bronchodilators and anti-inflammatory agents, and ensuring regular follow-up and monitoring. Thank you for watching. Please like, share, and subscribe, and we look forward to seeing you in the next video.